Good evening, attendees, and welcome to this third module of the Codeine Care Initiative Webinar Series. We will start in the next 4 minutes at exactly 19:05 to allow other attendees to join the meeting. Thank you. Good evening once more, attendees. The minute hand of my wall clock says it's exactly 5 minutes past 7. Thus, we will declare this webinar series open and start by pronouncing the house rules for today. We wish to indicate to you that all your mics will be muted throughout the webinar. And should you have any questions, you may post this on the Q&A platform provided on your Teams app. Ladies and gentlemen, this is the third webinar in a series of webinars focused on codeine and its use, and also providing expert guidance to healthcare practitioners across the country on its responsible dispensing, use, and application in patients and their ailments. Ladies and gentlemen, the first webinar focused on holistic management of pain, cough, and colds. The second webinar focused on reviewing the legislation relating to codeine in the country. And this is the third. It focuses on patient safety, and it looks at the place of codeine in pharmaceutical care. Ladies and gentlemen, there were questions from the previous webinar. We are going to address two of these. The questions were, can you report patients that are abusing codeine and are aggressive when you refuse to sell them? And how do you manage a person selling Schedule 5 weight loss medication on Facebook? The answer to both these questions is that you may report this to SAHPRA by visiting SAHPRA's website at www.sahpra.org.za. And then you may click on Contact Us, click on Whistleblowing or Reporting. And then once you are there, you may click on the form relating to complaints, relating to medicines and medical devices, and provide us as much detail as possible there so that we are able to investigate your report or your allegation. Without further ado, ladies and gentlemen, I would like to invite to the podium the Chief Operating Officer of the South African Health Products Regulatory Authority, Ms. Christelna Reineke, to introduce today's topic and open the webinar. COO, the floor is yours.
Thanks, Marimecha. Hearty welcome to everybody that joined us online this evening. As Marimecha says, this is the third session in our Codeine Care Initiative webinar series. And indeed, this evening we will be spending a bit of time with Johan and Andrew looking at patient safety, reflecting on what codeine's place is in pharmaceutical care, and looking also at the role of our healthcare professionals in supporting our patients with responsible self-care, and I think in particular looking at identifying or tracking those signs of possible misuse or overuse for these codeine-containing products. And also just looking at why codeine specifically is unique in the way that it's used for pain management. I think the focus that Andrew will bring also at looking and taking a different view on harm reduction. So in as much as we want to tackle the issue of misuse or abuse or inappropriate use, we also have to do it in a way that we, as they always say, first do no harm. And certainly I think that is something that we need to understand for our interventions to then be a sustained intervention where it actually benefits the patient and reduces the risk that the patient is exposed to in terms of potential overuse or abuse. How we could tackle that, and with these two colleagues giving us then two excellent presentations, hopefully we'll also be able to leave you with the bit of wisdom that they will share with us this evening. So please enjoy the presentations then by the two colleagues. We invite you, as Marimecha says, also to keep posting your questions in the Q&A section. And if we have time at the end of the session to then also deal with answering some of those. And one of the items that we just wanted to flag as well is that as we have been collecting questions over the webinar series, we are also compiling a frequently asked questions document, which at the end of the series, we will also then publish on the website. So at least that there is this information that you may refer back to as time goes by. For now, Marimecha, I think I'll pause here and give over to you guys to then hand off to our presenters who will take us through the material. Thank you.
Thank you, COO. Ladies and gentlemen, we will jump right into the webinar content. Our two experts today will focus on patient safety and the place of codeine in pharmaceutical care. The first expert to take the podium is Dr. Johan Kruger, who will be providing a pharmacist's view on the role of healthcare professionals in supporting patients with responsible self-care support and also providing guidance on patient safety and overdose management. Dr. Kruger, you may take the floor, sir.
Thank you, Marimecha. Thank you, Christiana, for the introduction. Just make sure, can you see my screen?
Yes, we can, Dr. Kruger. You may also maybe click your slide view at the bottom.
Thank you very much. Yeah, I'm a pharmacist, not a tech fundi there. As the two colleagues have said, a very important part of this third in the series of the Codeine Care Initiative. And I would really like to thank you all for taking your time, your most valuable commodity, and sharing that with us. As a practicing pharmacist for the last 40 years, I've been at the dispensing part of that. I've seen that, and I've seen both the harm and I've seen both the positive part of that. So I think, I'm very passionate about what I'm going to speak to you on this. There's the disclaimer here, the opinions and the views are my own. So we'll briefly be looking at where SAHPRA is standing with the CCI. CCI has been in existence since 2013, and what has changed lately. As pharmacists and as dispensers of medicine there, we need to know a little bit about the chemistry and the pharmacology of codeine. So we'll briefly look at that there. And then where the hoo-ha is coming from, and that's the substance abuse part where Dr. Scheiber will speak more, expand on that there, but I'll briefly touch on that there. And then I'll finish my talk on the dispenser's role. So the SAHPRA communique said in January 2020 that there were comments from the industry, and we believe that there is an effective method to control access to codeine-containing medicines there. And thank heavens, upscheduling did not seem to be the only way in how to address this. We've seen in some instances where upscheduling did not really change anything there, and we're very privileged and thankful for SAHPRA for giving us an opportunity as an industry to show, and by supporting SAHPRA in addressing this problem, because we see where the media is going with the abuse problem there, and the question is, what are you doing about it? And I think this whole program is going to answer that question there. So persons who are currently misusing, overusing, or abusing codeine, they're unlikely to change their behavior. We've seen that many times. They just change to another drug. They just change to something else there. Scheduling would also not address the potential diversion of codeine-containing medicine from regulated distribution channels. We know that it's not always the case where a patient hands in a false script or a script on their own name. It's very often stolen from trucks, from industry, from the harbor where it's offloaded there. So that might still happen, whether it's available with a prescription or without a prescription there. So SAHPRA is engaging in the CCI program in a phased-in approach, as there are many legislative changes that needs to be implemented. And we are ready to start with the pharmacy patient data recording. That is already in existence, and we can start with that as soon as we can go ahead. So what has changed from the initial ones there? Very important, we need to have a unique identifier. And the only unique identifier, or the most appropriate one, is getting the ID number, or in the case of a person that is not living in this country, the passport number there. And that is a statutory requirement. So patients cannot disagree on that. It is written in law. When they want any scheduled medicine from a dispenser, they have to give their ID number there. Medical schemes anyway require an ID number for patients for identification purposes there. So the whole industry, right from manufacturer, wholesaler, retail pharmacy, any dispenser of medicament, we're all in this program. And we want to see this solution work for everybody, for patients, for the industry, for pharmacists as well there. The CCI will include an end-to-end supply chain data. So in other words, from cradle to grave, where you will have the data from the manufacturer, through the wholesaler, through the pharmacy, right to the patient. And it will not just be dispensed data. They will come to that later on there. Pharmacy Council is developing a minimum standard on the supply of habit-forming substances. So Pharmacy Council is in this program as much as everybody else, one of the stakeholders, a very important stakeholder here. So the revised CCI will receive data on all sales of codeine-containing medicine at every level there. So the manufacturer to the pharmacy to the patient, through this already in existence software that we can use. If a patient hands in a prescription, the data is entered into the program, and it will flag or not flag whether the patient is in fact receiving too much of this, whether it's still okay there. It's very important to take note, and I said what has changed there, that the data is not only meant to be used by manufacturers, wholesalers, and pharmacies for the safety and the protection of the patient, but also by the authorities for regulatory enforcement there. And what that will mean is that if we find a pharmacy is purchasing 100 units of codeine, but is selling 500 of that, the figures don't match. And that is where the authorities will then have to step in, and whether that be the wholesaler or the manufacturer, all along this line. So it can be used for regulatory enforcement as well. And this is the part where myself as a pharmacist has been for many years there. We know what's happening there. If you have a patient that's coming in and handing in a prescription for either codeine or any other habit-forming substance there, and you have a Schedule 2 register and you keep your register religiously, and either the patient, when you start speaking to them, they just go pharmacy hopping or doctor hopping, or in some instances where you have an opportunity to speak to the patient there, you don't know exactly what to do with this patient. If the patient agrees that they are addicted to this substance, what do you do then there? So now the patient will be asked to produce the ID document at the time of the purchase. So that'll be checked against a central database, and it's a very easy program. There is no going out of the program, going into another site there. It is in your dispensing program. When you enter the patient, and it will automatically pick up if it's a codeine-containing substance, and if the patient has received it at another institution, either by accident or on purpose there, it'll immediately flag it. And then it'll be up to the discretion as you as a pharmacist or dispenser to address this in a professional manner. With this consolidated information, the pharmacist dispenser can make an informed decision. So you can then decide, really this is maybe just a little bit because it's a temporary thing, it's not a permanent thing, or you can see there's a real problem, and then you start addressing the problem. At least now you have the information available to arm you to handle this case in a professional manner there. So the objective then obviously is to monitor the sales of the codeine-containing medicine at the point of dispensing in order to minimize the potential for misuse, overuse, or abuse. Classical example, patient goes to a business trip to Cape Town, develops a sinus headache, goes into a pharmacy, gets a combination decongestant codeine-containing substance, which he or she then takes, gets onto the plane, as we all know, then develops a post-nasal drip with a dry cough, gets off at Tambo or wherever, and goes into the pharmacy and explains this dry, non-productive cough. The pharmacist advises a codeine-containing substance. On the way home, the patient stops at the regular pharmacy and picks up the chronic medication for the osteoarthritis, which contains a codeine-containing substance. The classical example where it's an accidental overuse. We're not just speaking abuse. So we are protecting the patient by having access to this information here. So the CCI then offers a solution for the continuing availability of codeine-containing substances as a pharmacist-initiated therapy for the benefit of the legitimate patient. We know that the vast majority of patients use it in a well-controlled manner for the purpose which it was intended for. So the ID or the passport number is the only information that is stored in case patients are scared in sharing this information with you. And then sanctions, including capping of supply quantities, cessation of supply, and reporting across the industry, will most likely also apply against institutions like pharmacies or doctors that continuously transgress this, where it doesn't match up the 100 purchased and 300 sold, that type of institution there. So differing sanctions can be implemented against these institutions there. Now, again, the question which I asked in the beginning, why the hoo-ha about codeine? What is really the problem with that? And I think as pharmacists and doctors, we need to look a little bit back at our chemistry and see codeine. We know it's a class of the drugs, painkillers, as the part of the opiates there. And opiates include all naturally occurring drugs with morphine-like effects. And such as codeine, and all semi or fully synthetic drugs such as heroin. The codeine is converted to morphine by your cytochrome P450 enzyme CYP2D6, and we know that it's mostly the morphine that has the action, the pain-killing action. Codeine's got a very slight action, as we'll see later on there. And then only about 10% of the codeine is converted there. We also have another enzyme, CYP3A4, which that produces norcodeine, and we use that for cough suppression, but it's also a substance for cough. Cough mixtures are also being abused there. And then I recently gave a lecture on pharmacogenetics, and this is very important, that genetically there are populations that are more prone to abuse, and there are populations where it's not really functional. Approximately 6 to 10% of Caucasians, 2% of Asians, and 1% of Arabian people are poor metabolizers. So they will not metabolize the codeine into morphine. And that's a typical patient which will come into your pharmacy the next day and tell you, you're wasting my time and my money. This stuff you gave me did not have any action at all. It's not working. And you can't understand, because the indication was exactly what it was intended for. It was supposed to alleviate the patient's pain, and little knowing that the patient is a poor metabolizer, or as we can see with West African people, that they are ultra rapid metabolizers. So hence the propensity to get dependent on the drug is much bigger. So that is also important for the legislator to keep into consideration when one looks at legislation and putting this drug in a specific schedule there. So codeine, again there, I'm sure you all remember that. It's an opioid. It's an agonist at the mu opioid receptor, MOR. So it acts on the central nervous system to have its analgesic effect. It's metabolized in the liver to produce morphine, as we've said there. And the receptors are G protein coupled receptors, and they can positively or negatively regulate the synaptic transmission through downstream signaling. So it can have an effect on itself there. Binding of the codeine or the morphine to the mu opioid receptor results in hyperpolarization of the neuron, and that leads to an inhibition of the release of your nociceptive neurotransmitters. Remember, the definition of pain is a nociceptive stimulus carried by the nociceptive receptors rather. And that reduces the neuronal excitability there. In other words, that's how it has an action there. So the pharmacodynamics of that there, as we said, it's an opioid. It's a mu opioid receptor there. It has codeine itself has got a relatively weak affinity for the receptor there. And it mostly functions as a prodrug in the sense that it gets converted to the active metabolite of morphine. And by codeine 6 glucuronide conversion there. So it doesn't need to be converted to morphine to increase the pain sensitivity. That is one of the factors that we also need to keep in mind there. So pharmacokinetics of that there, some medications are CYP2D6 inhibitors. In other words, if you take them simultaneously, it'll inhibit the conversion of codeine to morphine there. And one of the most pronounced ones here are the SSRIs, paroxetine and fluoxetine. And then, very interestingly, the antihistamine diphenhydramine. And how many of you know of codeine diphenhydramine combinations? There are many of them, and they are registered. So it means that the diphenhydramine is actually suppressing the efficacy of the codeine in that. So it's not quite a logical combination. Although one must admit it's not a total inhibition, it will slightly inhibit the action there. Bupropion has got the same type of effect. And then if you give the medication simultaneously with something like rifampicin or dexamethasone, that'll induce this cytochrome P450 isozymes, and it'll increase the conversion rate. So it'll make it a stronger drug, if I may call it like that. So it'll have a pronounced efficacy there. So that you might find that the patient experiences sedation. And then, of course, if it's used long-term with that, there is a possibility of addiction developing. So one has got to be very careful. One needs to look at the genetic predisposition of patients, but also look at the drug-drug interaction, which as pharmacists and doctors, we should be well aware of and take cognizance of that. This is a very important slide for us as pharmacists here. And that is how do we determine which painkiller to give. If we look at the different pains there in the top column, somatic pain, visceral pain, neuropathic pain. I'm not going to go through all the descriptions there, but if one goes to the left bottom column there, your most responsive treatments there. For somatic pain there, we'll see American description, acetaminophen, paracetamol there, corticosteroids, pharmacists can't give that there, local anesthetics. And yes, we've got NSAIDs and we've got opioids. The only opioid we have in our armamentarium is codeine. For your visceral pain there, again, there corticosteroids, we can't do that. We are limited for visceral pain then to NSAIDs and opioids. Neuropathic pain, very much the same, NSAIDs and opioids there. So that is what we as pharmacists have to treat certain types of pain. And we know how many people cannot take NSAIDs, either because of gastroesophageal problems there, of gastric ulcers, peptic ulcers, of hypertension problems there. So you are then only stuck with codeine there. So imagine if your codeine, your opioid is now taken away for you to treat pain. We live in a country where primary healthcare is such an important factor here, and we need to be able to address that. That's why the proper control of this is so important. So a little bit on what Andrew is going to talk about later on there, just briefly. A lot of us have done the drug-wise counseling program many years ago, including myself. And I think we've come to the conclusion that as pharmacists, we can mostly be intervening in a patient's addiction problem. We do not have the time and the ability and the knowledge to treat them. But we should still know what happens. Why do patients get addicted there? How do drugs work in the brain to produce pleasure there? And in the brain, we've got a reward system there. And when we use these drugs there, like codeine, it floods the circuit with dopamine. So we have a feel-good hormone there. And that rewards our natural behaviors. And a similar thing, much more less dangerous, is when we eat nice food. We will go back to the food because our reward system has been stimulated there. And that produces euphoria there, so we feel good. And what happens if we feel good? We would like to do it again. So it repeats that behavior there. So this is a slide that shows briefly the brain there, where the nucleus accumbens is where the dopamine is being released. And that is where the reward center is situated there. And we can see all the other centers in the brain, memory, quite near to the reward center, motivation, inhibitory control there. If we take a neuro image of the opiate concentration, we can see in the middle there where the reward center, what the concentration is like. So it concentrates in that area near the reward center. So therefore, to sum up then, basically, the need for pharmacists and dispensers to accept responsibility for the proper use of the medication. The need for a proper system to control the use of medication. We know that Schedule 2 registers are good for you in your pharmacy, but if we speak about a holistic approach to that on a national basis there, we need a proper system of control, and that is what the CCI is aiming at there. So the lack of effective control with current recording systems is something that we're well aware of there. So we need cooperation on a national level, all the role players, and especially from a regulatory point of view, like SAHPRA, Pharmacy Council are taking the lead in helping us address this scourge, and also at the same time get patients to reap the benefit for what is needed at that stage. And we must ensure that patients still have access to codeine at primary healthcare level, as I explained in the table about the pain treatment there. But we need to train pharmacists and dispensers in substance abuse. And I think often when we've seen a patient and we've decided that this patient has a problem, what to do now? And this is, I think, where Andrew is going to give us a lot of information on that. So thank you very much for your time. And with that, I would like to stop sharing my screen and to hand over.
Thank you, Dr. Kruger, for that wonderful and insightful presentation. Ladies and gentlemen, our next expert is Dr. Andrew Shaber, who is the technical advisor at TB HIV Care and also a researcher at the University of Limpopo, the University of Pretoria's Department of Family Medicine. Dr. Shaber will focus on opioid use disorder, stigma and discrimination in relation to people who use drugs, principles of harm reduction and treatment in relation to codeine use disorder. Dr. Shaber, you may take the floor.
Great, thank you very much. So what I would like to do to start is just, I think, build on what Dr. Kruger was saying around opioids and place codeine within that group of substances, and then speak a little bit around how a person experiences a substance is not just pharmacology and it's not just genetics. There are a whole lot of other things, and it helps to think of this framework called drug set and setting, and also to understand why people use substances and why it's important for people to recognize the value of pleasure and some of the reasons why people might develop dependence. And then I'll focus a little bit more on opioid dependency itself and spend a little bit of time around harm reduction and talk about the treatment of opioid dependence. So as pharmacists or people working in the health service, we may not always be aware of drugs and the range of them, and there are many new ones that are being discovered and developed frequently. So it can help to have a bit of an approach. And I work in the field of drugs and harm reduction, and I like to use something called the drugs wheel. And it simplifies the different classes of drugs and what their main effects are. So we get the stimulants, we get empathogens, we get psychedelics, and importantly, we get this class of substances called the opioids. And within the opioids, they either are derived from the opium poppy, which are the opioids specifically, or they are the synthetic opioids. And there are some that are illicit, which we heard earlier in the form of heroin. And then there are others that are regulated, like codeine. But it's important to note, as we heard, the way that codeine is modulated in the body to a form of morphine, like many of the other opioids as well. So it is part of the same class, and so it has a very important effect, but essentially it is less potent than some of the other opioids. It's important to note that synthetic opioids are an important global phenomenon, and I'll talk a little bit about in a moment with the crisis that's happening in North America relating to the potent stimulant synthetic opioids, including fentanyl and carfentanil. But you'll see there are other opioids of importance, and while we're focusing the Codeine Initiative on codeine, it's important to aware that there are many other opioids, particularly tramadol, oxycodone, hydrocodone, that can also be prescribed and should be prescribed with care because they form part of this class of medications called the opioids, which have a high dependency for developing dependence, which is slightly different to some of the behavioral aspects which were referred to. It's around the physiological changes that happen in the brain and the neurology of being exposed to a level of opioids in the body. So now when thinking about substances and this concept of drug set and setting, not everyone's experience of using a substance is the same. So this is very important to think about the reasons why people might use drugs. And in this case, it could also be a substance that's regulated, like codeine. It also, the influence it has on an individual depends on the dose. You know, how much codeine are they using, for example? What way are they using it? And what are the other individual characteristics? We heard that there are some genetic aspects, but also there could be comorbidities. It could influence whether or not the person is very elderly and may be more susceptible to the effects of opioids. But also importantly, it could be the context in which the substances are used. So if someone is using codeine, for example, in their home, in a safe space, the likelihood of harm to that individual is much less than if someone is opioid dependent and is using heroin or fentanyl in a place where they might be arrested, they might be using a substance where they don't know the potency, where there might be adulterants, or they might be exposed to other criminal activities. So all of these factors influence what a person's drug use experience will be, and also the degree of harm. And not all codeine use, as we heard, or not all drug use is associated with harm, but we know that all substance use, including medications, carry specific risks. So when thinking about substance dependence, it's important to be aware of the phenomenon of neuroadaptation. And when the brain is exposed to substances like opioids over a long period of time, there's a change that happens with the receptors. And over time, there's a change and a modulation that they become more sensitized. And over time, there's then a requirement for the person to have more of the same substance to achieve the same effect. Or if they don't have that substance and they need it, they start going into withdrawal. And withdrawal is a very important thing to recognize with people with opioid dependence, because it can result in people doing things that put them at extreme risk. So, for example, many of the individuals that we work with that have heroin dependence talk of scrounging in the street to find needles and syringes so that they can inject, not because they want to get high, but because they want to get rid of the withdrawal symptoms. Please, as a healthcare worker, never belittle or underestimate how terrible the withdrawal symptoms are for a person. If you think back on if you've had a very bad flu or parainfluenza, imagine that experience coming every 6 to 8 hours. So sweating, running nose, muscle cramps, tiredness, agitation, nausea, vomiting, diarrhea, which can continue until the person takes an opioid or an opioid agonist. So it's important to be aware that not all codeine or opioid use is problematic. And even if opioids or codeine are used for a non-medical reason, that once-off occasion in itself is not necessarily problematic. And with all drugs, the majority of people who use them or medicines do so without significant problems. When we think of mental health or we think of substance use, it's useful to think of a pyramid. And at the base of the pyramid, there are many people that have zero use. And then the large number of people who use that substance do so without significant harm to themselves or to individuals. Now, using the recommended terminology of the World Health Organization ICD-11, we use the terms of hazardous substance use, an episode of harmful use, a harmful pattern of use, and also substance dependence. There is an avoidance of the words of abuse, of addiction, of clean or dirty, because those words are not scientific and they're also laden with a lot of stigma. And what is important to note is many people who use drugs or many people that have an opioid dependence have a lot of stigma and experience a lot of discrimination. And many people who develop substance use disorders have a lot of underlying and mental health conditions. People have often been exposed to high levels of trauma, and we really want to not further isolate and stigmatize people. So when we're talking about substance dependence, there is a component of a behavioral aspect, which are those aspects relating to ongoing use despite harm, the substance use taking priority of other aspects of the person's life, including work or employment or family responsibilities. And then there's a prioritization and a difficulty of controlling use. Those are the behavioral components. But then there are physiological aspects, as I mentioned before, and that's either the development of tolerance or withdrawal, or the person identifying and seeking out substances that they can take that are of the same class or nature to address the withdrawal. And these things have happened either over a period of 12 months or if continuously over a period of 3 months. So those are the diagnostic criteria for substance dependence. And those would be applicable to codeine dependence as well. So how an opioid works, we heard the detailed pharmacology. I'm a simple person who tries to simplify things. But as we heard, if the opioid is in the case of codeine, if it's swallowed, it enters the bloodstream, it travels to the brain, and then it binds to the receptors. And think of the opioid receptors in the brain as a lock. And when the opioid comes into the lock, it then results in a cascade of effects. And these effects make the person feel good. It gives the person a feeling of warmth. It relaxes them and it removes pain. So it's very important to know that people use opioids because they feel good, and people do deserve to enjoy pleasure. However, if this is done excessively with opioids, we know that it can become problematic. With codeine, it's a short-acting opioid like heroin. So after 4 to 6 hours, the substance has left the body. But in someone who has got dependence, realize that by the time that the substance has gone through the body and the half-life is through, they will then start to experience withdrawal. So while codeine may not be as potent as heroin or as potent as fentanyl, people with the codeine dependence will still experience these symptoms. And it's very important as a healthcare provider to recognize that these symptoms can drive behavior. And if someone has got dependence on a short-acting opioid, that means that they have to use the opioid multiple times in a day. So if it's for codeine or for heroin, that means 3 or 4 times a day they're having to take the opioid, not to get high, but to avoid and manage withdrawal. So that's a very important component. Now, it's important to recognize the potential harm that can happen if we take very drastic approaches in trying to stop access to illicit opioids. So the United States is a very good example of the worst example of overprescribing opioids and then having a very strong response to scheduling. Because in the late 2015s, there was an increasing prescription of oxycodone and hydrocodone. In the response, there was a very strong legislation to stop the prescription. As a result, the people who already had dependence on those substances couldn't get them anymore. And so tens of thousands of people in America moved to use heroin. And many of those people, because of the war on drugs, started to use more potent opioids like fentanyl because of the more easy ability for fentanyl to be trafficked. So as a result, you'll see these are the overdose deaths that have happened in the United States as a result to their response to opioids and the response to try and limit prescription. So this is a very good example of what not to do, and we have to be very cautious in our context where illicit opioids like heroin are very widely and easily available. So harm reduction is a principle and an approach to recognize and be very pragmatic that people use substances and it's part of human life. But what we can do is we can help reduce those risks and respect human dignity and human rights and support people to have access to services and make informed decisions. So opioid substitution therapy is a form of harm reduction in that it doesn't require a person to be abstinent. The opioid substitution therapy, also known as opioid agonist maintenance therapy, is the treatment of opioid dependence. So it involves the provision of an opioid agonist medication, usually methadone or buprenorphine, at an appropriate dose for as long as a person requires it by a trained healthcare worker in a health setting with access to psychosocial services. It's important to note that this is the gold standard treatment of opioid dependence, and it has been in use for over 30 years. There is a very large wealth of normative guidance. In South Africa, the South African Addiction Medicine Society has got OST guidelines for South Africa, and the National Department of Health has got some draft OST guidelines. But it is a critical response to opioid dependence. So how does it work? If you remember earlier on, we spoke about the opioid operating in the mu receptor in the brain. These agonist medications, methadone and buprenorphine, act at the same receptor. And then it results in this downlit cascade. But what it does importantly is it addresses the withdrawal symptoms and also the cravings that people have. And these medications have a long half-life, so the dose and effect lasts over 24 hours. So this is the example of either the half-life of methadone or buprenorphine. So after 24 hours before the person will start to go through withdrawal. And in this situation, only single-day dosing is required. This is a very different scenario to someone who might have codeine dependence or heroin dependence, where they're having to dose multiple times a day, and if they don't have access to that, they go through withdrawal. So it's very difficult, almost impossible, for someone who's got a significant dependence to continue with their day unless they have the adequate resources. If every 6 to 8 hours they have to find and take an opioid to avoid withdrawal. And that's really what the medication does. It gives people a steady space to focus on other aspects of their life. And often that means the underlying issue that's contributing to the reason why they're using the opioid in a way that's dependence forming. Unfortunately, we have a problem in South Africa. We have an opioid crisis. We're focusing on codeine, but just be aware, we have about 400,000 people who use heroin daily in South Africa, and we have very limited access to opioid substitution therapy. In the public sector, it's not available. Methadone is on the essential medicines list, but only for withdrawal management, which means anyone that's admitted to a hospital in the public sector should receive methadone to manage the opioid withdrawal. There is, encouragingly, an OST pilot that the Department of Health will be starting in 2 small clinics in this financial year to inform the placement of methadone onto the essential medicines list for maintenance. There are a couple tertiary outpatient clinics, one at Stickland and one at the University of Cape Town, that provide OST, but the clients have to pay for the medication themselves. Similarly, in the private sector, this is a very big problem, is that the medical aids do not provide or cover opiate agonist therapy or OST. They provide detoxification services, which are not recommended. I didn't give the data here, but detoxification and rehab are contraindicated in many places because people are at elevated risk of returning to use and dying from overdose, or returning to use and injecting, and they then can contract hepatitis and HIV. Data from the South African inpatient treatment centers in Gauteng show that once people were admitted and received methadone for a few days, but then were on a detox program of 3 months intensive psychosocial services, within a year, 80% of them returned to heroin use. So it is a very ineffective approach, and that's why OST maintenance is recommended. There are some OST programs in South Africa. They are funded largely by donors. The city of Tshwane has got the community-oriented substance use program, which has 16 sites across the city of Tshwane, which provides methadone for people. And then you'll see on the map, in most of the major metro areas, there are small OST programs, largely funded by the Global Fund. And PEPFAR CDC funds in 2 services. But it's a major problem because this is what people need if they have an opioid dependence. So just in conclusion, be aware that codeine has the potential for dependency, and that treatment of opioid dependence is with opioid agonist therapy, or called locally opioid substitution therapy, which is a maintenance treatment. Be aware that withholding codeine from someone with codeine dependence has got very potential significant harms. That person's codeine dependence and their withdrawal will not go away by withholding the codeine. It will likely push them to access illicit opioids, which we've seen very clearly in the US. So, and there's a high risk of people transitioning to heroin, and many people who start using heroin progress to injecting heroin. Harm reduction is a pragmatic approach that recognizes the reality of life and tries to keep people alive and reduce the related harms. So as people working in the healthcare field, some key recommendations is reduce the excessive prescribing of opioids, but definitely use them when they're needed because they're such important medications. It is important to counsel people around the risks of dependence, not only for codeine, but also for tramadol, oxycodone, etc. And the prescription should be a limited use, particularly if there are doctors that are prescribing. As I mentioned before, be very careful of the words that we use with people. Addiction, being dirty, being clean are very stigmatizing words. So there are a framework of recommended terms, which I encourage you to look at, that are recommended by the International Network of People Who Use Drugs to try and avoid stigmatization. Because many people that have opioid dependence or codeine dependence have got underlying issues, and we want to support them, not punish them. So we should all be advocating for the inclusion of opioid substitution therapy as a maintenance therapy on the prescribed minimum benefits of medical aid and on the essential medicines list for primary care. And it's useful to adopt a harm reduction approach when engaging with people who use substances. Thank you.
Thank you, Dr. Shaver. Ladies and gentlemen, as we conclude the insightful presentation from Dr. Shaver, would like to then open the Q&A session for your questions. Remember, you may post your questions in the Q&A functionality on your Teams app. It should show at the top of the meeting screen. Additionally, we call upon yourselves to fill in a form that has been posted on the Q&A section of this meeting, indicating your attendance and also opting in or out of notification of future webinars. Ladies and gentlemen, I would allow a minute for your questions to be posted, and then we will return to the Q&A session shortly.
Madimecha, may I ask, whilst our attendees ponder their questions, if I could just invite Andrew just to bring up that last slide. On the slide, I just I kind of want to leave that there for all of us to look at those recommendations and really give that some good thought. Whilst we invite participants then to post their questions in the Q&A section. Thank you, Andrew. Madimecha, again, I am not noting any questions from the participants at the moment. So if you'll permit me to be very cheeky and just jump in. I'm completely out of order this evening, so I do apologize. But I just wanted to, whilst we're looking at these recommendations that are flighted on screen, I think for me, in closing, just to leave the attendants with some thoughts. I think we've heard from the two presenters this evening, two excellent presentations, helping us to reflect on the appropriate use and the role for codeine-containing products, but also reflecting at the same time the potential risks that may arise as misuse or accidental overdosing with these codeine-containing products. Looking at our role that we play as healthcare practitioners in terms of ensuring that patients who do use codeine-containing products derive benefit and are not necessarily harmed by using these medications, as they do have a role, specifically in pain management. I think Andrew is really, for me, left me with quite some food for thought in terms of, how do we as healthcare practitioners play a role in guiding our patients to have safe and rational use of these types of products, and always look at where we identify or spot a potential challenge or problem, that we engage then in a way that is constructive and helpful to our patients, deploying then harm reduction strategies, and ensuring that we encourage our patients to also, I suppose from that perspective, engaging in positive medication use behaviors, encourage where we can substitution if possible. And it's very important for us collectively to continue to engage, collaborate, all of the healthcare professionals, the regulators, as well as the patients, to create a supportive environment for harm reduction, and where possible, within our different networks and groups, to share best practices, potential resources that we can make available for each other, for patients, so that we can definitely enhance the collective efforts for promoting safety. Just to reflect then maybe on this last slide, just to kind of wrap us up. I think one of the things probably for me that stands out is adopting harm reduction approaches when we are engaging people with potential substance use challenges. And certainly for me, I think this is probably a topic that we might want to flag for future webinars as well. I think this is having a kind of like a how-to little toolkit is definitely something that's would be very useful for frontline healthcare practitioners. Would encourage you to also research on that a little bit, read up about it, reach out to some organizations, and let's try and focus on patient safety, putting our patients first, and making sure that we do whatever we can within the healthcare space to promote good, rational, safe use of these important products. Marimecha, that's kind of it from my side. I will get off my soapbox and hand back to you. Thank you so much.
Thank you, CEO. We have two questions. The first from Anonymous says, so is maintenance therapy, i.e. OST, indefinite, or can the patient be weaned off this? The second question, perhaps before I hand over to the experts, is from Santi Janse van Rensbeck, and it reads, it was mentioned that your pharmacy system will have the functionality to communicate with the proposed central database. Who is dealing with the software vendors? Thank you.
Marimecha, thanks. I think let me respond to Santi's question. And I will ask one of the colleagues, I will ask Andrew perhaps if he can share some reflections on the question around OST. So with regards to the system that we will be using for data collection, I think it's important also to note that when we are looking as the Codeine Care Initiative at using data to help us investigate and support, I think, our collective efforts around reducing the illicit use of codeine-containing products, The first phases that we will tackle will deal largely with collecting information from our manufacturers, from a manufacturer down to a distributor down to a pharmacy, so that we can ensure that there is movement of codeine-contained products in the authorized and legitimate supply chain, that we don't see that these products end up in unauthorized channels. That's the first thrust. The second thrust would look at some activities with regards to the information regulator around POPI, and how we will then ensure the legislative mechanisms is in place for us to be able to collect this treatment information, and also then, as indicated in the presentation, be able to have that in a shared database so that we could prompt intervention where intervention is then required. So in terms of who's dealing with the software vendors, that would be something that we would then manage when we get to that particular phase through the Codeine Care Initiative. Thanks, Santi. Andrew, then I can maybe hand over to you, perhaps?
Thanks. It's really important to note that if someone has opioid dependence, it's a chronic condition. So we know that all chronic conditions are very hard to manage. And often we have unrealistic expectations of someone that has a substance use disorder that they can change or stop it very quickly. So we would never anticipate, for example, for someone being treated for hypertension, that we could just give them a treatment duration for 6 months or a year. However, it's very common to have that expectation of someone with a substance use disorder, and all that is discrimination. So think of codeine dependence as a chronic condition, and so some people will need treatment for life, and some people will need treatment for a less period of time. The evidence is very clear. The longer people receive treatment, the better they do. So when you hear people wanting to wean people off or to stop people, just think, would we do that to someone with hypertension? Whenever thinking of the management of a substance use disorder, think of it if it wasn't substance use, and see how we have these intrinsic, entrenched stigmas when it comes to substance use disorder. So the short answer is, it's an individualized treatment plan. The World Health Organization is very clear. People should get treated for as long as they require it. The treatment impact is better if people receive the appropriate dose. And generally in South Africa, there is underdosing because of the high cost of the agonists. And people generally do better if they also have access to psychosocial services. Over.
Yeah. Ladies and gentlemen, this has been a great webinar, very insightful. I'm going to invite the Chief Operating Officer of the South African Health Products Regulatory Authority, Ms. Reneke, to come and close the webinar. COO, the floor is yours.
Madimecha, thanks. I think just, thank you also for the questions raised by the participants. For me, this is such an important topic that we are grappling with in South Africa, actually globally, to be fair. And I think a lot of this also just with the challenges that a lot of people face in their day-to-day, the struggles that we've got, that seems to be more prevalent nowadays from a mental health side. And it really is, I think, those principles, if you can be anything, be kind first. And for me, probably that is also something that we have to, as the healthcare practitioners, look at making sure our patients are safe, that we can provide support in our different roles and our different capacities, let us do so. I think so important the role that we play in terms of identifying excessive opioid prescribing, providing then counseling and support where there are certain misuse patterns identified, and making sure, I think, as we said, that we do it in a way that we are kind as well as responsible. Madimecha, I think from my side, just thanks for the presenters, thanks for the attendees, and I wish you all a very good evening further.
Thank
Thank
you.
you.
Good evening.
Good night, everybody.